Here I am in the operating room. We have completed a cataract surgery with implantation of an intraocular lens, and I'm positioning the head. I will rotate the head itself about 30 or 35 degrees away from me and tilt the scope towards me. I then will focus the microscope on the distal limbus to get those vessels into focus, because I find that then when I place the gonio lens, the angle structures will be in perfect focus. I use a cohesive viscoelastic both in the anterior chamber and on the surface of the eye. It doesn't really matter which viscoelastic you use, so if you have some leftover dispersive viscoelastic, you can use that. You want the chamber filled, and that'll prevent corneal striae. So here we have a good view of the angle. We see a few PAS from argon laser trabeculoplasty, but nice blood reflux into the canal, and we're ready now to bring the dual blade into the eye to open up the canal of Schlemm. The dual blade has a tip that can comfortably pierce into the canal through the trabecular meshwork, and then the two blades have a ramp. The ramp puts tension on the outer wall of the canal and the trabecular meshwork, and it removes a strip of trabecular meshwork as you move along. This is a so-called inside-out technique, where I start really in the middle of my view and go superiorly and then inferiorly. That will leave two strips of trabecular meshwork, which can basically be left alone. They do not need to be removed from the eye. They're very benign, and they often roll up on themselves, leaving you with a good area of open canal. Placing more viscoelastic to improve visualization for my second pass, going now in the other direction. So again, this is the inside-out technique. You can otherwise start from the ends of the arc and move towards the center, and in that case you usually will remove a strip of trabecular meshwork.